You're listening to Season 2 of Medscape's In Discussion series on idiopathic pulmonary fibrosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Jeff Swigris, pulmonologist and professor of medicine in the Center for Interstitial Lung Disease at National Jewish Health in Denver, Colorado. Dr. Swigris specializes in the clinical care of patients with interstitial lung disease and directs research centered on how interstitial lung disease affects how patients feel and function in their daily lives, how to best measure those effects, and how quality of life may be improved for patients suffering from interstitial lung disease. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Jeff Swigris, and welcome to Season 2 of the Medscape In Discussion podcast series on idiopathic pulmonary fibrosis. Today, we're going to discuss a topic that is relevant to many of our patients, and that is considerations around supplemental oxygen. And I can't think of a better guest to be with us today to discuss this topic than Susan Jacobs. Susan is a research nurse manager in the Department of Pulmonary Allergy and Critical Care Medicine and a nurse coordinator in the Interstitial Lung Disease Clinic, all at Stanford University in Stanford, California. She was the lead author on the American Thoracic Society Oxygen Clinical Practice Guidelines, and she chairs the American Thoracic Society's Oxygen Special Interest Group. Susan, welcome to the Medscape In Discussion podcast.
Oh, thank you, Jeff. It's outstanding to be here.
Before we dive into issues related to supplemental oxygen, tell us how you got interested in the field of interstitial lung disease.
So I thought about this, and it comes down to two patients that really made a profound impact on me clinically. I was, as you may know, in critical care nursing for much of my early career. And then I transitioned to outpatient and managed a pulmonary rehabilitation program. And there were two gentlemen with IPF who would arrive at our exercise area, walk in from their car, and had the most profound breathlessness, tachypnea, and what I would call nerve-rattling desaturation that I just wasn't used to, different from my other patients with obstructive airway disease. And there was no treatment except to give them oxygen and, of course, supportive care. And when I came to Stanford in the late 90s, we were just starting to see very early clinical trials for patients with IPF. And these patients came to our clinic desperate for treatment, and their families and caregivers so impacted by the burden of symptom. So it really has always pulled at me to do more for this population, patients with interstitial lung disease and IPF. It was 16 years after I started at Stanford until we got just 2 drugs to treat these patients. Now it's been another 10 years and 20 negative trials later, and we're still hoping for better treatments for these patients. So I see this as a huge unfilled need. It's really hit a nerve with me, and it continues to do so.
You highlight one of the key things about fibrosing interstitial lung disease. You saw those 2 patients walk into your rehab center with profound peripheral oxygen desaturation, and we know that our patients need more oxygen than patients with COPD and obstructive airways disease. So issues around supplemental oxygen seem so relevant to our patient population.
They really stand out as different. And we've seen the data on that. They desaturate even starting at the same baseline as patients with obstructive disease and even similar PFTs, pulmonary function testing. This decline and the rate of decline is much steeper for those with restrictive lung disease, fibrosis.
I'm going to remind the audience that when a patient is prescribed supplemental oxygen, typically what they will get is a stationary concentrator. And for those who need supplemental oxygen with activity, for example, when they leave home, there are portable devices. And the stationary concentrator is a unit anywhere 30 to 50 pounds or thereabouts. It may provide oxygen up to 5 liters per minute continuous flow, or some up to 10 liters per minute continuous flow. They plug into the wall and run on electricity. The oxygen is concentrated and then delivered via cannula to the patient. Can you remind us, Susan, what options are available for patients who need oxygen outside the home? So portable oxygen.
So for portable oxygen, there's 3 options. Compressed gas would be probably the most common. These are the metal green cylinders that you see in multiple sizes, from a wine bottle size up to the roughly 2.5 feet tall e-tanks that we see. The e-tanks are 15 pounds with a trolley that they need to pull them. And with an e-tank at 6 liters a minute, it may last not 2 hours. And sometimes these patients have to have a dual trolley and bring 2 of them because they need to switch over at that high flow. And there are some home fill units. That's a unit you sit on top that stationary concentrator. The patients can put a metal canister and refill their own oxygen at home. Those are smaller canisters and they take a long time to fill. So compressed gas, one choice. The second are the portable oxygen concentrators. And as you mentioned with the stationary, it's the same mechanism. These purify the air coming in, remove the nitrogen, spit out oxygen around 85, 90%. These run on a battery. They are lightweight. These are the purse size that you see a lot of marketing in magazines and such. 3 to 10 pounds. There are a few that are much heavier, but they're rare. And the battery life of these POCs varies. It's a shorter battery life at higher settings and higher respiratory rate. The battery won't last as long. A POC with a double battery setting at 2 might last 3 hours. At 4, it'll last less than that. So the POCs are quite portable. They plug in and the batteries can be recharged. The third option is liquid oxygen. This is oxygen that has been super cooled down to like minus 300 degrees Fahrenheit. Typically, patients have a large reservoir in their home. It's refilled weekly by a durable medical equipment company, or DMEs, we call them. And they have a portable canister that they click onto this reservoir, switch a switch, it fills, they unhook it, and they can leave the house. The difference is that liquid oxygen, you can fit a lot more oxygen in a smaller space because of its characteristic. So these portable canisters are maybe 6 to 8 pounds. The reservoir, as I mentioned, gets refilled weekly by the DME. And these patients can use this on continuous flow up to 15 liters. So 4 to 15 continuous flow. If they're at 6 liters, they'll get at least 3 hours out of a canister, and they can fill more than one. It does evaporate over time if it's not used. But the portable oxygen concentrators are really limited by the amount of oxygen they can supply. So liquid oxygen is harder to come by, but liquid oxygen is the only form that really provides high continuous flow in a portable canister.
So let's first talk about liquid oxygen and talk about the way you described it. I'm sitting here saying, well, why wouldn't all my patients go for liquid oxygen? Why aren't more patients using liquid oxygen?
The access to liquid oxygen took a dramatic change around 2010-11. And the reason for that was Medicare implemented what we call a competitive bidding reimbursement process. So it changed the reimbursement process to these durable medical equipment companies, which caused payments to the DMEs to drop substantially for all types of oxygen. These cuts were enacted after those Medicare Modernization Act, Balanced Budget Act. And so over about 10 years, these reductions in reimbursement impacted the DMEs dramatically. And because liquid oxygen is the more expensive form of portable oxygen to supply, that was the first service they cut. So for a DME to provide liquid oxygen, it takes specialized trucks, trained professionals to drive and deal with this hazardous material. It means a weekly trip to the patient's home. So if a DME is getting $150 a month per patient and they're paying a driver 4 times a month round trip, and if they're out in a rural area, their payment is gone. And we can see this in the Medicare claims data. The number of patients who use portable liquid oxygen dropped from 41,000 users in 2010 down to 8,000 users 2016. So the lack of access after competitive bidding to liquid oxygen is very clear and widespread. It's available in some pockets around the U.S., but it's very rare. And the predominant reason is financial, that the DME simply can't afford it.
And we already talked about our patient population, those with fibrosing interstitial lung disease, who typically desaturate more profoundly, by extension, tend to need more oxygen. This competitive bidding process where DME companies were given less money after 2011, less money per patient, and those cuts were made, it will have a bigger impact on our patients. Again, just to level set, what Susan mentioned was that CMS, Centers for Medicare and Medicaid Services, will reimburse durable medical equipment company X amount of dollars for services. And in 2011, that amount was cut. And so DME companies were forced to cut costs. And as Susan mentioned, dealing with liquid oxygen, storing it in these huge refrigerated, I call them silos. I'm not sure exactly what they are, but you see them around hospitals. And that's expensive. And paying these specially licensed drivers with their special trucks to keep the liquid oxygen cold is quite expensive. And so DME companies said, well, there's an opportunity for us to slash costs. That's what was done. And so many patients who once had the opportunity to use supplemental oxygen were no longer afforded that opportunity. And here in Denver, where the elevation is 5,200 feet and barometric pressure is so low, and our patients by definition will need more oxygen than at lower elevations, it really profoundly impacts our patients as well as many others around the country. Talk to us a bit now about portable oxygen concentrators. Again, those seem like, well, gosh, here's a relatively lightweight battery-powered thing. What are the limitations of portable oxygen concentrators?
Portable oxygen concentrators, for many patients, and remember, we have 1.5 million oxygen users in the U.S., many patients' needs are met by a POC, as we call them. But let's start with talking about the setting and the quantity of oxygen they can deliver. The numbers on a POC are not liters per minute. And this is a very confusing area for both patients and clinicians. So primarily, POCs deliver oxygen using pulsed flow. And pulsed flow is different than continuous flow, and that pulse delivers a bolus of oxygen with each inspiratory effort by the patient. So there's a lot of things around that. The patient has to be able to trigger it. Does it get triggered well? With our patient population that have a very rapid, shallow breathing rate, especially with exertion, it triggers this bolus. It's delivered during inspiration. It shuts off during exhalation. This is a conserving mechanism. So it allows a POC to last longer, and the batteries can last longer. And the same kind of oxygen conserving device, by the way, a regulator, can be placed on the metal tanks as well, just to clarify that. The problem is that when you calculate the delivery of oxygen from a POC, even at a setting of 6, it's less than 2 liters a minute. It can be around 2 liters a minute. And the most common settings are 1 to 4. Some POCs offer 5, 6, and 7. But these are settings, not liters per minute. And so it's very confusing. In our ILD clinic, for example, we test the patient. We do the oxygen titration to determine what flow rate they need with walking. And we're using an E-tank in most cases. And the prescription is written, this patient needs 4 liters per minute to keep a saturation above 90%. The patient gets delivered their oxygen equipment. They get a stationary concentrator. Medicare covers one modality of portable. They want the POC, of course, because they can fly. This is the only FAA-approved modality for portable. They can plug into their battery. And they go, oh, put my POC on 4. It's a setting of 4. It's not 4 liters of continuous flow. In our population, this population of fibrotic lung disease, the concern is that these patients sometimes are either provided this POC from the DME, or they go online and buy their own because they're very attractive. There's a lot of marketing to the patients, only to find that they, quote, outgrow them very quickly, unfortunately, because of the trajectory of this disease. They may have spent $2,000 to $4,000 on a POC, and that pulse delivery system just does not adequately oxygenate them, especially with exertion. They may be fine when they're sitting, visiting with family or at a theater, but to get up and move, it may not adequately provide them with enough oxygen. And even to more add to the confusion, a setting of 2 on one POC may not provide the same amount of oxygen as on another POC. So there's not consistency between devices. So it's a very confusing area. And our group in the American Thoracic Society have reached out to the FDA about labeling and devices and transparency. And there's some patient education from some of these POC companies. It's not clear to the patient. So the bottom line is that we tell patients, you must be tested on the device you're going to use and follow your oxygen saturations by pulse oximetry. That's really the bottom line. Determine if these are adequate. So we need device research. We need device development. I mean, it really brings up a whole nother topic for what we need in R&D, right, for this patient population. So high flow patients are relegated back to an E-tank, a very heavy, burdensome device that some patients can't manage and end up being homebound. And our goal is to keep patients out of the home and active. So the POC's limitation is the quantity of oxygen they can deliver.
Right. And I am frequently frustrated. It seems like every week I see a patient who has a POC, a portable oxygen concentrator, and they say, I was told I needed 3 liters per minute and I put this on a 3 and I'm still desaturating. And I bang in the drum that I want these settings labeled with letters rather than numbers to try and avoid the confusion. And it's not just patients. A lot of practitioners are equally confused or assume that these numbers, these numeric settings represent liters per minute. And as you so nicely summarized, they certainly don't. Limited supply of liquid oxygen. POCs don't deliver enough oxygen for many patients. The settings are confusing. Compressed gas can be heavy and unwieldy, particularly when you're dealing with E-tanks. But maybe there's some good news on the horizon, at least to deal with some of these issues. And I'm talking about a bill that was recently introduced into Congress called the SOAR Act of 2024, Supplemental Oxygen Access Reform. Can you give us a brief overview of that bill, Susan, and just tell us where it stands in Congress and what we can look forward to there?
So this SOAR Act is really the result of about 10 years of action in a really, what I would say is a extraordinarily multidisciplinary coalitions of patients, professionals, nurses, physicians, respiratory therapists, and multiple foundation groups that, and as I summarized, following the competitive bidding saga, came to hearing so many patient complaints after competitive bidding was implemented. This includes the American Lung Association, pulmonary fibrosis, COPD, American Thoracic Society, respiratory care, chest, pulmonary hypertension, primary ciliary dyskinesia, LAM, alpha-1. Oxygen transcends so many patient groups. This coalition has been meeting and working at developing a legislative bill, which we're very happy to say has now been formally co-sponsored by both the House and the Senate, bipartisan. And now the real work starts. We're working on getting more co-sponsors to get this bill to go through with likely a larger Medicare package by the end of the year. So what does SOAR encompass? So it's 4 pillars, as we call this, of Medicare oxygen payment reform. And the first is to remove all oxygen and oxygen equipment from Medicare competitive bidding and really ensuring that this is patient-centric. And this means we are asking them to change the name of this benefit is currently home oxygen. We want that mindset change. So it'll include changing it to supplemental oxygen. We want our patients out of the home. The second is to ensure access to liquid oxygen for patients for whom it's medically necessary. We understand this doesn't apply to every patient. And in doing this, it will establish a separate payment rate for liquid oxygen to assist the DMEs, we hope, in providing that. The third pillar, as we refer to them, creates a new add-on for reimbursement for respiratory therapist services. I can't say how important this is. I didn't mention that in addition to losing liquid oxygen, another cost-saving measure was, of course, not including professional respiratory therapists on staff of these DME companies. So not only could clinicians call and discuss issues and oxygen need, but we would be ensured that our patients could be tested in the home when they were provided equipment, that they could be educated. Another huge lapse that patients don't get and their families enough education. So this third pillar would create a new add-on for reimbursing respiratory therapy services. And then the last is more of a documentation standardization to help establish protection for Medicare beneficiaries against fraud, abuse, establishing some standardized documents for ordering templates and that sort of thing. So those are the four main tenets of the SOAR legislative bill. We were very fortunate that very little of that was changed from what we proposed. So we are now working to get other co-sponsors. And I would make a plea to any listener, whether you use oxygen, prescribe oxygen, know someone that uses it, that you go online and contact your representatives and senators and push for them to co-sponsor this SOAR Act. We have a lot of work to do between now and the end of the year.
With respect to listeners actually going somewhere, should they go to American Thoracic Society, American Lung Association? Are there templates out there that they can use?
There are many templates. I would say, and I just did this the other day, if you just Google SOAR Oxygen Reform Act, many of these organizations will come up. If you're involved with the Pulmonary Fibrosis Foundation, yes, you can sign on that website. There are templates for everything, how to talk to your congressman, how to write a letter to the editor. You can call and get assistance. So yes, every organization has these. So you can just Google and go to the group of your choice. It's pretty well messaged. Personally, I feel like we're not asking for a luxury item here, right? We're just asking that they be allowed to have a normal oxygen level.
You mentioned one of those pillars of the SOAR Act, getting the respiratory therapist back involved. I know when I have patients come in, I think they feel like they're isolated on an island. And if they're new to supplemental oxygen, somebody delivers this big 50-pound thing, says, plug it in, turn the knob to this number, and they have no idea how to deal with it, what they should be doing. And they got told what they're supposed to be doing by the delivery person rather than somebody who's well-informed and could be a valuable resource for them. Do you have resources or support, either pages or networks, that you send your patients to around issues related to supplemental oxygen?
Yes, the answer is yes. There are outstanding resources, videos, paper resources, online resources by many organizations. Our challenge is to disseminate these, to get them to the patient. So the Pulmonary Fibrosis Foundation stands to me at the top for this population. They have outstanding oxygen information around general information, traveling with oxygen, understanding Medicare benefits, offering it in multiple languages. We have an obligation when we prescribe oxygen to offer patients these resources. And I also want to mention managing expectations. We have to be clear to patients. This isn't going to take away your shortness of breath. We can't promise exactly. Benefits vary patient to patient. We believe, if you have a lot of resting hypoxemia, this can be life prolonging. And if you're active, we think it can allow you to do more with less breathlessness. But we do try and get education out. I was just on a call with the Pulmonary Fibrosis Foundation this morning, and it comes up again and again. We don't need to create new resources. We have outstanding resources. So the Pulmonary Fibrosis Foundation for this population makes sense. That's their home. There are others. The Lung Association, CHEST, I know others have great videos on using oxygen, multi-language offerings, safety. We haven't talked about safety, fire hazards, tripping, power outages. We can get it out to academic settings, but how about these community and primary care practices, rural community? How do we get this great information out there? It is there. If only the office had just a list of websites and handed that or attached it to their after visit summary electronically so it's automated to get them that information. And I would also say support groups and pulmonary rehab are the other two areas they will get great information and support among others who use oxygen, which is really something they need to share with each other. There's some great information, but it's just making sure they get it.
Susan summarized nicely this aspect of supportive care, whether it's emotional, psychological support, supplemental oxygen, pulmonary rehabilitation, all components of this more well-rounded supportive care that we like to offer our patients with ILD. So we've come to the end of our time. I've been talking with Susan Jacobs, who has done amazing work in spearheading movements around improving access to supplemental oxygen for our patients and others. Susan reminded us about how supplemental oxygen can be supplied to patients with portable oxygen concentrators, liquid oxygen, and compressed gas. She told us about the 4 pillars of the SOAR Act, and I will echo Susan's plea to please, if you're listening, contact your representative and senator in the U.S. government, and let's get this SOAR Act passed. We'd like to see that done by year's end. Thank you so much, Susan, for joining us. It's been a real pleasure, and it's been educational for all of us. So thank you for joining us.
Well, Jeff, thank you very much for the opportunity. The pleasure.
And thank you all for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on idiopathic pulmonary fibrosis. This is Dr. Jeff Swigris for Medscape in Discussion.
Thanks for listening to Season 2 of Medscape's In Discussion Idiopathic Pulmonary Fibrosis podcast series with our host, Dr. Jeff Swigris. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on idiopathic pulmonary fibrosis.